documentation principles. And the goal of this presentation is to identify the principles that form the basis of documentation for all nurses. And these principles apply to documentation in all practice settings, including any care that's provided virtually. So for the definition, documentation is a nursing action that produces a written and/or electronic account of pertinent client data, nursing clinical decisions and interventions, and the client's responses. And it happens in a health record. So documentation is an integral part of professional nursing practice. It is not separate from care and it is not optional. And care is really not complete until documentation is complete. So it could be written or electronically generated client information, and that information is obtained through the nursing process. And it is through documentation that RNs communicate observations, decisions, actions, and outcomes. So quality documentation establishes accountability. It promotes quality nursing care. It facilitates communication between healthcare providers within their circle of care. It helps inform the plan of care and the standard requirement, and it conveys the contribution of nursing to healthcare. And documentation may also be required for legislative compliance, such as with the Personal Health Information Act. Documentation is important because it reflects the application of nursing knowledge, skills, and judgment, and the client's perspective. It is a written record of the substantial contribution that nurses make on client outcomes, and it's very important. It establishes the record of care provided to the client, and it can be used to justify change or improvement in quality care. So documentation is used in a lot of quality improvement initiatives, and it's used in a lot of research for funding and resource management. A lot of those places require documentation to be reviewed in order to make proposals for new funding sources or for changes in healthcare. It's also used in legal proceedings. So when you're thinking about your documentation, it must be complete enough to refresh your own memory of something that may have happened many years prior. So it is the single most important piece of evidence in a court proceeding. And when you're charting, that's why it's important that you chart chronologically the care that was provided to the client. Because the court looks at a written chart as the care being provided by the nurse. And all your documentation is used as evidence. So it needs to be made as contemporaneously as possible. There's a lot of weight to put on your documentation. However, there are many factors that influence documentation. So the complexity of your client care. So if your client has increased instability, there needs to be increased documentation. It could be based on your employer policy. So different employers had different policies of how frequently you need to chart, according to the environment, the employer setting that you're working in. Could be based on your practice environment. We know that there's different charting accountabilities for like intensive care units or the operating room or neonatal ICU. And there's different methods or formats for documentation. It could be DAR or SOAP or charting by exception. And now there's increases with uses of technologies. So we have virtual nursing practice and we have our electronic medical record. So with the documentation principles document, it's been changed to be broad-based principles to account for all of these factors that are influencing documentation. So as long as you have the broad principles met, then, the different factors influencing documentation, you're still within your standards of practice. So like poor documentation creates uncertainty in the care provided for the collaborative team, and it has, the potential for negative outcomes for the client.
Okay, so Yeah, thanks. So as registered nurses, we provide safe, competent, and ethical care to our patients. And part of this care is adhering to our standards of practice, which includes documentation. And there's an indicator in our standards under standard 2 that speaks to the requirement for documentation. So we're going to take a second to reflect on some of the following statements. And registered nurses, you need to be able to say these statements with certainty. So the first one, I maintain timely and accurate documentation. So what does that mean to you? To maintain timely and accurate documentation. And throughout the presentation, we'll reflect on that very statement. I know that documentation is part of the care I provide, and it's important for you to reflect on that. Do you document all aspects of the nursing process? Do you evaluate after you administered a pain medication what response the client had, and did you document it? Documentation, I know, is not optional. It is a part of the nursing care or practice that you provide. So it's not something that we just say that we're not going to do. And I understand the client's record is a legal document, and we'll discuss this concept a little bit more in detail. However, I will leave you with the statement, not documented, not done. So as registered nurses, you're expected to document the patient's story in a clear, concise, and unbiased manner. So these are some of the things that, as a registered nurse, that you need to reflect on, that you incorporate into your practice each day. Okay, so I just said that it's in the standards, the indicator for documentation. So CRNNL, or the college, has been granted authority to develop, maintain, and promote standards of practice through self-regulation and through the RN Act and RN regulations. And because we're a self-regulated profession, you must be able to say that you hold yourself accountable to the standards, which are the expectations for nursing practice. And the requirement for documentation is embedded in the standards of practice for RNs and NPs and the code of ethics. And the college's practice guideline that we're talking about today, documentation principles, is to be used in conjunction with our standards of practice, our ethical code, and relevant legislation that applies to documentation, and evidence-informed best practices. And as best practices evolve in documentation, we need to be advocating to our employer or our clinical educator or professional practice to update our documentation policies. And and as part of a nursing practice and the standards, we have a expectations for practice diagram in our standards that talks about the expectations for practice. And one of those circles that's in that diagram talks about specialty standards and position statements and guidelines. And this is exactly where our documentation principles fall, is that we have a practice guideline that outlines the expectations for registered nurses when they're engaging in documentation. So what are standards of practice for RNs and NPs? And this is just a quick synopsis, is our standards are broad, authoritative, principle-based statements, and they provide a legal reference for reasonable, prudent nursing practice. So they outline the minimum expectations for nursing practice. So as I said, as a part of our standards, there's an expectation for registered nurses and nurse practitioners to engage in timely and accurate documentation. And our standards protect the public by supporting safe, competent, compassionate, and ethical nursing practice. And the standards further define responsibilities set out in legislation and regulation, and they articulate what is expected of a reasonable, prudent nurse. And our standards are used by the public. The public can go to our website and review our standards. They're used by registrants, they're used by organizations and employers, and the government. And the standards apply to all nursing, all registered nurses, in all domains and practice settings. So no matter if you're a manager or a frontline registered nurse or nurse practitioner, or you're a VP, then if you're engaging in nursing care, then there's an expectation to document. So what does it mean to be accountable? Well, accountable means that you're answerable for what we do, how well we do it, and for what we decide not to do. And that you're answerable to your client, to your employer, and even if you're self-employed, there are expectations for self-employment. There's legislative requirements that you're answerable to. You're responsible for working within your scope of practice and knowing the scope of practice of others. So it's also then really important that you're answerable. If you decide at the end of a busy shift that you're too busy, you had to get the kids to the skating rink, and you decide not to document the care that you provided for your clients during your shift, then you'll be answerable for that decision if that arises as an issue, or you have conduct deserving a sanction brought against you in the form of an allegation. Peggy, back to you.
So standard 2 is, like Michelle said, as part documentation is embedded in your standards. And standard 2 is knowledge-based practice, and the indicator 2.7 states that an RN maintains accurate and timely documentation. We're going to discuss what accurate and timely means. And the standards of practice, like Michelle said, are the minimal expectations for registered nurses, and therefore documentation is your must do. So documentation principles. So we used to have documentation guidelines for registered nurses and nurse practitioners. And one of our other colleagues, Rolanda LaValle, in consultation with the College of Licensed Practical Nurses, Newfoundland and Labrador, and with stakeholder consultation and engagement from registered nurses and nurse practitioners across Newfoundland and Labrador, revised our documentation document and made it principle-based and a lot smaller. And it's basically 9 broad principles. And it is those principles that can be applied to a variety of settings, a variety of circumstances. Like we said, that there's many things that influence documentation. But if you adhere to these 9 principles, then you are meeting your standards for documentation. So the principles, when you look at the document, they're not listed like principle 1 is this, principle 2 is that. They're just broad principles because they're not sequential, like 1 is not better than 2 and 2 is not better than 9. All of the principles apply equally. So the first principle is documentation is a component of care. So documentation is a part of care, and it's not additional to care. So when you think about providing care, then you have to document afterwards. That's still part of you providing care. And regardless of the method of the delivery of care. So it could be virtual care or it could be care in person. And if it is virtual care, that requires more extensive documentation. So if an RN is relying on virtual methods only for assessment, so you cannot see, you cannot, well, you probably see, maybe see, but if you cannot touch, you cannot auscultate or anything, your physical assessment and how you gather your information on your patient or your client, documentation should be extensive. So the basic principles and expectations for quality documentation, both written and electronic, are the same, with the exception that the electronic documentation may pose a greater risk for breach of privacy and confidentiality. And if you want further information on that, CMPS has an info law called quality documentation, and that pretty much states that electronic documentation carries a higher risk of breach of confidentiality. Policies and procedures, as well as specific technologies, are required to protect the confidentiality of the patient's health record and system security. And this is especially true when you're transferring information from one site to another. And with electronic documentation, you must know how to use the system, that there may be some variation in the way the electronic data is recorded because software. However, you are responsible to ensure that you're educated enough to use it and that you can follow the basic principles. And nurses should document the virtual platform that they're using to provide care and make sure to obtain any consent to offer the service virtually, and the geographical location of your client if it is truly virtual care. Another principle, not the second, is that documentation supports the safe provision of care. So documentation must be concise, objective, legible, chronological, and provide sufficient information for the seamless delivery of safe and competent care. Who provided the care, any changes in the patterns of the client's status, and the outcomes of the evaluations of care. So the health record or your chart should accurately reflect all information that was provided to prepare the client for any transitions like admission or discharge or transport. The client's status at the time, any education that you provide, arrangements for follow-up, evidence of the client's understanding, and as appropriate, family involvement. So what does the safe provision of care actually mean? Factual, objective, and accurate. So we're supposed to use objective terminology when describing observations. So one that I can have as an example is a lot of times a nurse will chart, or any healthcare provider, patient fell out of bed. And if you're thinking about being as objective as possible, if you walk into the room and the patient is on the floor, then you don't know that the patient fell out of bed. You should chart that you walked into the room and found the patient on the floor. So that's just being as specific and as factual as possible. We document statements or feedbacks from others by indicating what was stated and by whom. And if it's a direct quotation, you can use quotation marks. Be precise as possible. So the use of words such as appears or seems or apparently demonstrates uncertainty, especially within a court of law. So, patient seems to be resting well, or seems pain-free, or appears to be sleeping. That doesn't actually tell you if the patient is sleeping. It demonstrates uncertainty in your critical thinking and your decision making. And use only the abbreviation symbols and acronyms articulated by the employer as acceptable. And that just helps with making sure that you're communicating what you actually are meaning to communicate, and there's no misunderstandings. So mistaken entries or errors must be corrected according to employer policy. Some employers say that you must leave the content of the mistake clearly visible and just put a single line through it, and then put your initials by it with the date and time. But you need to ensure that you're following your employer policy and that corrections are made. Do not leave blank spaces. That leaves the opportunity for somebody else to write in there, or another person to add information, which is from an unknown author. You need to have accurate spelling and legibility. Misspelled words or ineligible entries could result in the misinterpretive information and lead to an adverse event. And in a court of law, it really decreases your credibility. And validate that you have the correct client record. It's very simple, especially with the electronic records, to just flick between different patients. So you make sure you document client information on the correct record, and then every page of the health record must contain the unique patient identifier, whatever they use in your employment setting. And the copy and paste functions on the electronic health record may result in inaccurate, outdated, or incomplete information. So try not, even if you did this assessment earlier, it's better for you to, not hit shift and enter to copy and paste your exact last. There could be a significant change that you might not think is, you might not think it's significant, but even a small change should be documented as part of the client's record. And back over to Michelle.
Thanks, Peggy. So another principle detailed in our practice guideline is documentation includes all aspects of the nursing process. So that includes your assessment, your nursing diagnosis, planning, your implementation of the nursing intervention, and the evaluation of the outcomes of care. So the nursing process provides a systematic and sequential guide to planning and providing care, as we all know. And the plan of care identifies a client's health status, that's your assessment, and the actual or potential health problems, which is your nursing diagnosis. It establishes a plan to intervene in meeting the identified needs, which is your planning phase, identifies nursing actions, which is your implementation of the nursing competency or intervention, and allows for determination of the effectiveness of the plan, which is your evaluation in meeting the client's healthcare needs. So it's really important that you follow employer policies surrounding electronic authorized practice. So when you're documenting, you need to follow your employer policies, whether that's in the written form or in the electronic documentation. And it's also really important that you follow your employer policies for any type of authorized transfer of information, for example, emails and the use of mobile devices. So, is it your employer policy that you're sending an email for a consult? Does that have to be a secure email? If you're texting a physician about the client's blood pressure and condition of a wound bed, is that an accepted policy to be texting? Is it an acceptable or an appropriate mobile device that you're using? So most regional health authorities do have policies on the use of mobile devices. So if it's an approved, there has to be some method of that information, that transfer of information via that type of media to enter into the client's record. So if there's a process where you can hook up that an employer approved mobile device, and you can hook that right up into your Meditech system or your EMR to transfer that information. And there's a policy that approves that, then you should use it. If it's your own mobile device and there's no policy on texting a physician or a nurse practitioner for the plan of care of your client, then you should reflect on whether you should be using that or not. So again, according to CMPS, you should also avoid preparing personal notes outside the client's record. The legal chart is the client's record through your employer. So documentation, which reflects the nursing process, demonstrates that an RN has fulfilled their duty of care. So if you have quality documentation and you follow your standards of practice and code of ethics regarding documentation, then your chances of having conduct deserving of sanction is probably nil. So it's really important that we pay attention and we document all aspects of the nursing process. The next principle in our document is documentation includes client-related communications with other healthcare professionals. And this is really significant. And all significant client-related communications with other healthcare professionals, including written, electronic, verbal formats, and unsuccessful attempts, should be noted in your documentation. So if, throughout the night and the NP is at home on call or is, busy in the OR and you're unable to, get in contact with that physician or NP, then that needs to be documented. Also, if you call, the NP and you review your assessment with the NP, and there's treatment options or orders or a direction or change in the plan of care, that all of that is documented, what information was relayed to the healthcare professional, and then what direction was provided to you. And it's really important that at that time you note the date and time of the contact, the information that was provided, and the response received from the other healthcare professional. And if communication is unsuccessful, it's not enough to say that I notified the doctor or I notified the MP and do nothing about it. It's really important that you document information about what other alternative channels that you pursue to ensure client needs or services are met. And that may be involving calling the manager on call. It could be involving calling the site clinical manager. There may be, an alternative nurse practitioner or a physician that for that program that you may be able to call. So whatever process is laid out in your employer policies of what to do when you're unable to get that practitioner, when you have to, relay what's going on, that change in acuity of your client, then that needs to be documented and followed. So another principle is that nurses are responsible and accountable for documenting the care they provide. So care provided by other professionals is documented by those professionals. So for example, if you're assigned to a number of clients and you go on break and you do a handover, and then while you're gone, your client has some, abdominal pain and requires, some Addisol 30 or, some Demerol or morphine, and that healthcare professional, whether it's an RN or LPN or administers that medication, then that care should be documented by that healthcare professional. So you document the care that you provide, and if someone covers for you or while you're on break or gone to the washroom, then that care is documented by that individual healthcare professional. And there may be times when there's a shared assignment of an LPN and RN, depending on the predictability or accountability of the client. And in that circumstance where the client is not as so unstable or unpredictable that the care is transferred to the nurse, but the nurse is, following the status of the client, then the LPN would chart what they do, and the RN would chart what care that they provided. So there are some circumstances where a designated recorder may be identified in select circumstances. And that may be in a code blue when there's a cardiac arrest. It may be in the operating room when the scrub nurse is unable to, where they're, scrubbed, they're not able to document, where there's a nurse that is charting in, the OR manager and doing the counts and all that where that information is being recorded by a designated recorder. So that individual is unable to document the event as it occurs, so that person would be designated by the employer as being the designated recorder. So it's according to CMPS, I actually attended a session virtually with CMPS most recently, and a tip that they said is that if you have a designated recorder of your care, you should review the documentation that has been recorded to ensure that it's accurate. And so really important that you think about that. And I'm sure there are circumstances, for example, also in GI endoscopy, where the nurse is, assisting the surgeon to do a scope, and they're garbed up and they're not able to provide that documentation. There may be a designated recorder. I often think back to when I was in labor and delivery, and you're in the middle of a delivery, and it was very difficult to record as a delivery is going on. There may be circumstances where we jot things down on a piece of paper, but whatever you're writing down needs to be into the chart. So are you able to transfer that information, that piece of paper, into the chart? If not, if there's circumstances where you're not able to do that, then you really need to advocate to the employer for some type of record or a designated recorder so that you're able to chart at that point of care rather than jotting things down. We often get questions about co-signing, and students are expected to document the care that they provide in accordance with employer and academic policies. And the registered nurse is educated at a greater depth and breadth than the nursing student. So if they sign and co-sign a student's entry into the documentation system, they're basically saying ditto. So the co-signed RN should record their own assessments and interventions and evaluations. It's not saying that they can't co-sign, because if everything is exactly the same that they would document, then you would have to check your employer policy and your faculty or school nursing policy. But technically, an RN has been educated at, as I said, a greater depth, and they should record their own assessments and interventions. Next principle, the documentation occurs at the time the care was provided or as soon as possibly afterwards. So documentation is not completed before care is provided. So you can't, sit at the desk at 2 o'clock and document that you did a bed bath at 6 p.m. That's you should reflect on really is that in the best interest of the client. Documentation should occur as close as possible to the time of the care, the provision of the care. And this enhances the accuracy and the overall credibility of the health record. I know many years ago we would sit probably at 2 o'clock and chart all the morning care. But the best practices today and the principles in documentation is that you document as close to the care as possible, as contemporaneously according to CMPS, that's their term they use, but as close to the time of care as possible. And in situations where documentation is not timely, it should be written as a late entry. So as I said and gave an example, is that we should never document prior to the care or service being provided. We need to reflect on whether that's really something that we should do. For example, we chart in the MAR that we've given our medications, but we haven't administered them yet. So just one of those principles to adhere to. It's really important also that you document chronologically. And documenting chronologically enhances the clarity of communications and enables healthcare professionals to identify the care that was provided to the client. And it shows changing patterns in clients' health statuses and the outcome or evaluation of the care. So that chronological documentation of the client's care should allow for seamless transfer and delivery of care between healthcare professionals. So anyone picking up that chart within the circle care should be able to read through, what's happened to that client on that shift. If it's more than just the RN or LPN caring for the client, if social work came in to provide services, if OT came in, it should be all documented chronologically. And as I said, for a late entry, if you're not able to do it at that point of care or as soon as possible, then it should be recorded as a late entry. And late entries include the date and time of the late entry, as well as the date and time of when the care or intervention was provided. And in some instances, there could be a lost entry, and that could be due to a computer malfunction. And unfortunately, that may be something that the system is going through now. And the nurse may be required to reconstruct the entry if it's lost. So the new entry must clearly indicate the information recorded is a replacement for a lost entry. And if the care or event cannot be recalled, the new entry should state that the information for the specific time of the event has been lost. And as I said, in this current situation, when there is a computer malfunction, I'm sure there are employer policies that guides how you transition back to paper documentation. So you follow those employer policies for the requirements of switching to paper, how long you continue to document, how long before you would have to transcribe that information back into your Meditech system. So it's basically following what your employer policies are if there's, a computer malfunction, because I know most of you are probably doing electronic documentation at the present time. Next slide. So we're just going to talk a little bit about the complexity and risk influences, the risk that's involved in the client's plan of care and status influences the frequency of documentation. And frequent documentation supports accuracy, so that, you know, if someone picks up that chart, they can see how the client's status is changing. And if you document frequently in those circumstances, then it can be very accurate of what's occurring. So if you're taking a blood pressure every minute because the client's status is changing or due to a response of a medication that's been administered, it can show how that and what care has been provided. The frequency and amount of detail required in documentation is actually dictated by several factors. And I alluded to some of that in just speaking, but the complexity of a client's health status. So if a client's status is changing, they're becoming more unstable, more unpredictable, their clients are getting more acute, then we would certainly document more frequently as we're, you know, monitoring the client's status. If there's changes in the plan of care, that's really important to be able to communicate that with the rest of the team within the circle of care, and that, you know, if, you know, different interventions are ordered and this is not charted, then that could lead to errors, you know, happening in the client's care. The degree to which a client's condition puts the clients at risk. So there may be, you know, circumstances that are occurring on the floor, or that that is involved in, you know, transfers or whatever, that those need to be documented. The degree of risk involved in a treatment or component of a care. So, you know, if there's, when you're doing client education and you're reviewing things that the client needs to know about, or you know, how to do like insulin administration, those kind of things. All of that needs to be documented. Whatever type of education or you know, whatever instructions are provided to the client about the degree of risk, that needs to be documented according to the employer policies. And employer policies also identify a required frequency of documentation, as well as the format used in the practice area. So as Peggy said, that could be a SOAP note, it could be a DAR, it could be charting by exception. You know, it could be that you're required for alternative level of care, maybe that you only chart once a shift, or, you know, so that would be laid out in the employer policies of how frequent you document. So documentation, as Peggy said, should be concise, it should be factual, it should be objective, and documentation should be more comprehensive and in-depth and frequent when the client is very ill or exposed to a high degree of risk, to ensure the client's record is fully capturing the complexity of the client's condition and the care that is being provided. So that that evidence of nursing care is provided in the chart.
So our next principle is that nurses safeguard client privacy and confidentiality in all forms of communication. And nurses do this in a variety of forms. So in electronic documentation, we ensure that our access is controlled using passwords and other access requirements. And nurses understand that it's imperative to maintain security of usernames and passwords, and to use the appropriate safeguards, including like making sure that you're logging off. Nurses safeguard privacy and confidentiality in accordance with applicable legislation, including your Personal Health Information Act. And in the Personal Health Information Act, you should be very familiar with it, because some RNs and NPs in self-employed practice can be considered the custodian of the client's record or the personal health information. So they have to have the appropriate safeguards as outlined in legislation to mitigate risks such as cybersecurity attacks, to make sure that, you know, the client's record is double locked, that you have the two-factor authentication for computer systems and so on. So the nurse's role in safeguarding clients' privacy and confidentiality really comes from your employment setting, and it should be outlined in your employer policy. But it is a principle when you are documenting that you need to keep at top of mind. So only information relevant to the client care is documented in the client record. And sometimes, so the client's record is the client's. So they don't need to know in their client record about quality improvement or risk management or your occurrence and safety reportings. All of those methods of documentation are separate and distinct from the client's record. And that should be outlined in your employer policy or captured somewhere in your employer policy. So when you're documenting, you document about the client's care, the nursing process, the client's care. So legislative compliance, and we do this almost intuitively, but we comply with our professional duty to report and in accordance with legislation. And one of it is for FIA, for example. So requirements for reporting in relation to legislation include the Public Health Protection and Promotion Act. And with our COVID times, we are all very familiar with that. The Gunshot and Stab Wound Reporting Act, there is different legislative compliance for documentation there. Narcotics lost or theft, and you can also have some requirements in relation to legislation if you look at the Canada Vigilance Program. Another principle is that documentation demonstrates respect for the client's choices. And nurses are the ones who are with clients most frequently of all the members of the healthcare teams. And we have an ethical responsibility to respect a client's informed choice, even if these choices may pose risk to the client's overall health. And, respectful documentation is devoid of any value judgments about the client's choices and behaviors. So we now have just two quick scenarios. Michelle's going to do one and I'm going to do one. Just about two examples of documentation and how you can apply these principles.
So I know that we're virtually, so it's a little bit difficult to identify some of the errors that's in this note. But so I guess the question that you pose yourself, so does this meet the standards of practice in respect to documentation? I guess I kind of gave it away. There are errors here in this note. So do anyone that's able to, do you want to pop into the chat some of the errors that you see before I go through them? Yeah, that's correct. Spelling errors, absolutely. For diabetes in the second line, it said diabetes, and patient, there's an R in it. Absolutely. Great pickup. Okay, so I'm just going to briefly go through the note. And, the first, use of never. Absolutely. How do they think, is drunk? Absolutely. So, yes, that's right.
Say it, yeah.
So, absolutely. So, saying that the person is drunk, that's very biased, and you need to be concise. So you would say that the patient, and objective, thank you, and that the patient smells of alcohol, those behaviors that would demonstrate that they're drunk, not that being judgmental and saying that the client is drunk. Also, January 1st, 2021, there's employer policies, and usually it's day, month, year, according to Meditech, and there's no time for when the note was written. The use of abbreviations. Is PT an approved abbreviation by your employer? Came to emerge. Emerge is abbreviated again. Is that appropriate? Again, you guys came up with absolutely. This is not appropriate objective description of the client. Had a large cut on the left side of the head. Okay, well, how large is the cut? What's the length? Is it, poorly approximated? Is it gaping? What is there bleeding from it? Where on the left side of the patient's head is the cut? He never lost consciousness. By what? What would demonstrate that they haven't lost consciousness? You definitely picked up about the history of diabetes is spelled wrong, and some heart problems. Well, what heart problems do the client have? And the wife was complaining because he was waiting too long to be seen. Is that really relevant to the client? So only those comments that are relevant to the client's care that are made by the client, the family, or the substitute decision maker should be included in the note. And I paged the doctor and he never answered. Okay, well, who did you page and at what time and how long you waited and what was your follow-up? What did you do when you didn't get anyone to answer your page? Dry dressing applied to the head. Well, what type of dressing and where on the head? And waiting for the doctor to see the patient. Absolutely. It's a wrong spelling. And what doctor? And then absolutely, someone just said that Pam. Well, Pam who? Because under your standards and your professionalism and your code of ethics and your entry-level competency, the expectation is that you sign your first and last name and your professional designation.
Our next one was October 21st, 2019 at 1610. Patient, abbreviated temp up and plus drainage from abdominal wound. Patient CO of CP earlier on the shift, but settled now. PT ordered 5 to 10 milligrams of morphine, SQ, Q4, PRN, meds given for pain. Doctor texted for further direction regarding temperature and census parameter given to patient, wife visiting, IV infusing well, no further problems noted, spending a good day. So that was S. Lewis RN. So if you look at that note, I wouldn't think that he was spending a good day. But you can put into the chat some of the things that you think need to be improved on in this documentation. And yes, I would include the physician's names. Yep. What is the temp? Too many abbreviations. IV infusing well. What was infusing? What the temperature is? What type of drainage? Exactly. So you guys all know all this.
They certainly do.
Yeah. So exactly, like, again, is it an approved way to do the date and time? Patient's temperature up, what was it? Some employers use plus drainage, but it wasn't described, like if it wasn't serous anguish or seropurulent or purulent. Abdominal wound, where was the wound? How deep was it? There's no description. Patient, I'm assuming CO is complains of. I never liked using the word complains of because they're not complaining, they're just reporting their symptoms to you. So I always used reports. CP, I'm assuming that's chest pain earlier on the shift, but they're settled. So what was the morphine ordered for? Did they actually give it? Or meds given for pain, but was it morphine? Sub-Q is not an approved, SQ is not an approved abbreviation. Again, Michelle mentioned about texting. Is texting a part of your employer policy? Do you have an employer approved phone? Can that phone be deleted remotely? How do you know who's on the other side? And the doctor was texted for direction regarding the temperature, but they didn't mention the chest pain or the drainage from the abdominal wound. The census parameter was given to the patient. I don't know what they did with it. The wife was visiting, that's fine. Again, somebody mentioned what type of IV, where was it? Is the angio catheter assessed? So even though they had all those things today, they had increased temperature and abdominal pain and drainage and chest pain, and they were given morphine and an census parameter, they still had a good day. So that's just a couple of, very funny examples of how charting can go wrong. But to summarize.
Okay, to summarize, documentation needs to be credible and it needs to be defensible. So it's really important that you ensure that your documentation is accurate and complete. It's factual and it's objective. There's no value judgments there, any biases, that you accurately and objectively report what is happening and occurring to the client. As I said before, it needs to be chronological. It needs to be permanent and legible. It's not recommended that you use pencils, excuse me, if you're doing paper documentation. It's also recommended that you should reflect on if you're able to use the same pen that you're charting one. And I know sometimes we run out of ink, but again, the credibility may be questioned if you're writing with a blue pen and then you switch to a black pen. So again, you need to follow your employer policies. It needs to be contemporaneously, so as close as possible to the care that was provided. It needs to be full English language. And in previous presentations, Peggy and I gave some text talk examples, but it's really important that we not use, language like LOL, laugh out loud, those abbreviations that are used in text language. It has to be full English language. Or appropriate language that whatever practice setting you're in, if it's French or another type of language, but whatever is appropriate in that situation that you need to document in Newfoundland would be English, but not reverting, because we're seeing a lot of documentation, a lot of notes that are progress notes that are being written that are more like text talk, and that's certainly not appropriate. It doesn't meet the principles, it
doesn't demonstrate professionalism.
Absolutely. See, we even know what we're going to say. It's been in sentences for each other, but absolutely, it certainly doesn't demonstrate professionalism.
And I just want to go back one slide, because just to demonstrate chronological, if you looked at this one, and we're assuming in this record that this is written chronologically, so that first the patient's temperature was up, and then they had drainage from the wound, then they complained of chest pain, but it said earlier this shift. So if we do it chronologically, it should be that the patient, reported chest pain during their shift and have reported instead of complains of, and chest pain spelled out. Then it would say, so that would be your, assessment. You would chart your assessment, what you did, then your action, so what you gave them, and then your evaluation would be that it's settled now. So your action might have been that you ordered 5 to 10 milligrams of morphine, and that's what, from the physician, and that you gave those for pain, and then it was settled. So you can see how, having it chronological and contemporaneous makes it a more accurate reflection of the client's day and how they progressed. So then maybe after the chest pain, the registered nurse or nurse practitioner noticed drainage from the abdominal wound. What type of drainage? What did you do about the drainage? Did you take a swab? Did you change the dressing? And then they noticed the patient's temperature was up, and then they, call the doctor for further direction regarding the temperature. Then what did you do? So that's just to go back and, show the importance of being chronological and contemporaneous.
Yeah. And Peggy, also, like for accuracy in that one, it said there was a range that, 5 to 10. Well, what exactly, how many milligrams did you administer to the client, and what was the response?
Yeah. So what does this slide represent? And everybody knows what this slide represents. So you could be the best nurse in the world, and 15 years down the road, well, probably not that long, but if it's not, if you can't prove it, it's not documented, it's not done. And this.
And this is our new website. If people are registrants aren't aware, we actually went live about a week or so now with our new website. So I encourage everyone to get online and have a look for our website. And just to make you aware that those 3 lines that are there by the search icon is where you would click, and then you go to practice, and all of our documents are located under practice resources, and they're actually arranged by practice topics. So under that page, if you go into documentation, you'll find the documentation principle. And in the next few days after this presentation is archived, we will move that presentation, and you can find it there also under our archived events. So as I said, it's a new website. We also have new social media platforms. We have Instagram and Facebook. So you'll have many methods of getting in contact and being able to access our resources. So I encourage you to go in, have a look. If you have any issues of trying to navigate it, just give us a call. We look forward to hearing what you think of our new website.
So the website's still a work in progress. We're working out the little bugs that we have in it. But if you can't find anything, you can use that search button or the magnifying glass there and just type in the name. And it's really good that it's by topic. So everything that has to be, that's associated with that topic, if you look under that topic, it's there. So you'll find the practice guideline, you'll find the archive teleconference session, you'll find any external links and things like that. So we only have like a very short period of time left. If there's any questions, please feel free to either type them into the chat box or unmute yourself, and we'll be happy to answer. If you don't want to ask any questions right now, or you're thinking about them later, we're available anytime by telephone or by email. So you can call or email us anytime, and we'll walk you through whatever question you have.